OsteoSignal episode 29. This is OsteoSignal with Neil D. O'Neill, a podcast exploring how your body's natural design connects with osteopathic science, translating complex signals into practical insights so you can truly thrive.
Iron, the brain, and the hidden currents beneath cerebrospinal fluid. How iron metabolism shapes cerebrospinal fluid dynamics, dural tension, and cranial autonomic regulation. You can't move cerebrospinal fluid, or CSF, regulate the vagus, or keep the brain clear or clean without the smallest of metals, iron. And the smaller it gets, the louder its absence speaks. Welcome to the OsteoSignal podcast, where we go underneath the surface of clinical practice and into the biology that actually explains how the body heals, adapts, and breaks down. I'm Neil O'Neill, physical therapist, clinical osteopathic manual therapist. My work sits at the intersection of manual therapy and translational research, taking the science that lives in journals and converting it into hands-on clinical methods that restore adaptive capacity in real patients. Neuroendocrine signaling, biomechanics, immune regulation, autonomic function. I bring all of it to the table because the body doesn't organize itself into the silos that medicine uses. Joining me is Autumn Mayberry, osteopathic manual therapist. Autumn's clinical work integrates structural treatment with the body's autonomic, endocrine, and visceral systems. She brings a depth of patient care perspective that keeps everything we discuss grounded in what actually happens in the treatment room, not just what looks good on a whiteboard. Hey, Autumn.
Hey, Neil, how's it going?
Going well. And guiding the conversation is Brent Mayberry. Brent is an engineer by training, which makes him the ideal person to ask the questions you're probably already thinking. The ones that push us to translate the deeper physiology into language that's clear, practical, and useful on Monday morning. Hey, Brent, how's it going?
Hey, I'm doing well, Neil. Good to be with you again.
Yes. Together, our goal is straightforward: to explain and to explore the signals that regulate human health, biomechanical, bioelectrical, and biochemical, and to understand how osteopathic manual therapy supports the body's ability to adapt, regulate, and recover. Not managing disease, just surviving, moving people towards thriving. Okay, today's episode is going to take you to a place most clinicians don't connect: the link between iron metabolism and the mechanical and electrical health of the brain. Specifically, how iron, ferritin, and the way our bodies handle this single metal shape cerebrospinal fluid dynamics, dural tension, and cranial autonomic regulation. If you're a clinician, you probably check ferritin once in a while, maybe in a fatigue patient, maybe in a runner with iron deficiency anemia, maybe in a woman with heavy periods. And then you move on. What I want to do today is to convince you that ferritin is one of the most informative and most underinterpreted labs in the entire panel. Because iron isn't just an oxygen carrier. Iron is what powers the choroid plexus, the structures that produce cerebrospinal fluid. It's what runs your brainstem nuclei. It's what makes dopamine and norepinephrine, what regulates vagal tone, and what, in the wrong amount, starts to drive the slow currents of neurodegeneration. Now, if you're a patient listening, you may have been told your labs are normal, while you feel anything but. There's a good chance iron is part of that story, and we're going to talk about how to read that story properly. So 3 things today. First, the basic physiology of iron, enough that we can speak about it precisely. Second, the 4 big places iron meets cranial physiology: the choroid plexus and the cerebrospinal fluid, the dura, the autonomic brainstem, and the neurovascular bed. And third, the OsteoSignal lens, how a manual therapist thinks about all of this and what it means for the patient on the table. So let's get into it. Okay, so what does iron actually do? Iron is the most abundant transition metal in the body, about 4 grams in an adult, give or take. 2/3 of that is in the red blood cells as hemoglobin. Some of it is in muscle as myoglobin. A small but absolutely critical fraction is in every other cell, doing things that don't involve carrying oxygen at all.
Hey, Neil, real quick.
Yeah.
Could I just ask you, what is a transition metal? Is that just, the type of metal that it is on the periodic table? now
It
that I
is
think about
exactly
it.
that.
Okay,
It's
so
just a
they
place.
call,
Yeah.
yeah, there's a certain range on the periodic table that are transition elements. I just remembered that from chemistry. But for those
Good
listening
job.
at home who don't remember, so on the periodic table, there's some, I don't know, segment of the table that has certain elements as transition metals, and iron is one of those. So sorry about that.
Oh, no, a very important distinction, because what the heck does that mean? That's
Yeah.
why we have Brent here, folks. Keep us in line.
So yeah, so
Hey, wait a
listeners, you
second.
might be wondering, what transition? What? I thought
Right. What does
at
that
first I
mean?
thought it had something to do with, like a physiological process in the body, but no, it's just the periodic table. So, all right.
There we go. Okay. Okay. So let's see. Okay. So where iron lives in the cell, mitochondrial electron transport. So there are these complexes, 1, 2, 3, 4, the chain that produces nearly all of your ATP. And remember, ATP is the adenosine triphosphate, is the energy source of your cells. The ATP are put together in your mitochondria so that you can play games with electrons and suck energy out of them as they fall in their energy levels. Now, every one of these complexes, 1 through 4, is built around iron, either iron sulfur clusters, so FES. And some of you may have heard that. We've started making batteries for electric vehicles out of FES. Finally, we're copying humans or copying mammals. The other places you find iron is in heme groups embedded in cytochromes. Those are just structures within a cell. But without iron, the electron transport chain stops, period. No energy. DNA synthesis and repair. Ribonucleotide reductase. When I say ribonucleotide, you should think RNA. And there's an enzyme that helps break that down. So that's the enzyme that produces, so ribonucleotide reductase is an enzyme that produces the deoxyribonucleotides for DNA. It has a di-iron center, meaning iron is on either side of it. So cells that divide, like the rapidly turning over choroid plexus epithelium, lining the ventricles in your brain, the fluid-filled areas of your brain, are iron hungry. They need lots of iron to do their job. Catecholamine synthesis. In the news recently, we've seen that taurine in drinks is problematic. It's slightly related. Obviously, tyrosine is an amino acid that's in taurine. Tyrosine hydroxylase, the rate-limited enzyme that converts tyrosine to L-DOPA. L-DOPA, you might know, is the dopamine, is the neurotransmitter in the brain that helps us perform many of our functions, integrates many of our functions for our cells, directs our attention, et cetera, et cetera. So this is L-DOPA is the precursor of dopamine and norepinephrine. So that ability for fight or flight mechanisms. And those also require iron as a cofactor. No iron, no dopamine. That's problematic. Myelination. Oligodendrocytes, brain supportive cells, use iron heavily during myelin synthesis. Now, remember, myelin is the fat that coats the surface of the axons of the nerves to make them be able to transmit their messages much more quickly. So it's a demyelination diseases, or a lot of those brain diseases we know that are not good for us. So brain iron deficiency in early life leaves a measurable myelination signature for decades. So if you don't myelinate properly early on in life, that's going to affect your brain for quite a long time. Nitric oxide signaling. Many of the heme proteins involved in nitric oxide production and sensing are iron-based. Vascular tone, including in the brain and the dura, run partly on iron. So it really shows you how nitric oxide, one of the functions that it performs is that it actually opens up the capillary to allow a red blood cell to be able to slide through there, because as we learned in a previous podcast, red blood cells are actually larger than the capillaries. And so in order for the red blood cell to be able to go through there, not only does the red blood cell have to have appropriate iron to make it more malleable, but also the capillary bed itself has to get nitric oxide. Well, it can't get that nitric oxide, which makes it more distensible. It can't get that nitric oxide if we don't have the correct amount of iron in our body. Because remember, iron will be preferentially held onto for red blood cells and in hemoglobin. So that doesn't do us a whole lot of good. However, if the capillary beds can't make nitric oxide and enlarge themselves to allow the red blood cell through. So we'll have all the red blood cells we need, but we won't be able to get them through the tongue. Okay, so when we talk about iron deficiency, we're not just talking about anemia. We're talking about a metabolic shortage that touches energy production, neurotransmitter synthesis, DNA repair, myelination, and vascular regulation, all of which the brain depends on heavily. So how iron is regulated. The body has no efficient way to excrete iron. We lose roughly 1 to 2 milligrams a day, mostly through cellular turnover and in menstruating women, through blood loss. So absorption is tightly regulated, and the gatekeeper is a hormone called hepcidin, made by the liver. Hepcidin tells the gut and macrophages to release or hold iron. When the iron is abundant, hepcidin rises and absorption falls. When iron is needed, hepcidin falls and absorption rises. But, and this is the trap that catches most clinicians, hepcidin also rises in inflammation. The body, evolutionarily, hides iron from pathogens by sequestering it in macrophages. So a patient with chronic inflammation, autoimmune disease, obesity, or even untreated periodontitis can show high ferritin and a clinically iron-restricted state at the same time. So periodontal disease can be one of the chronic inflammation states that we're talking about. So this is anemia of chronic disease, or more accurately, anemia of chronic inflammation. The iron is in the bank, but the bank is locked. Okay, so how to read the labs. When we want to see this, we want to know exactly what's going on. If you remember nothing else from this episode, remember this. Ferritin is two things. It is the body's primary iron storage protein, and it is an acute phase reactant, always. Let's talk about those. So here's how I would read the labs. Ferritin under 30 micrograms per liter is iron deficiency, full stop. The patient is deficient even if hemoglobin is still normal. They have not yet decompensated into anemia, but the tank is dry. And there's one of the biggest problems that we see. We see people that are well below that 30, but still above the 15 or 20 that is the bottom end. And they're being told, no, actually, you're fine. You just need to eat more. And that's not the story. If they are below that 30 micrograms per liter, they are iron deficient, period.
I see that all the time.
Yeah. Yeah. You see a lot of people hanging out in that area for years. And you have to look at old labs, and you can go back 3 to 5 years and you're going, wow, that's horrible. Or it's at least explanatory, right? It tells us about why people have been feeling the way they have for years.
Yep.
Now, ferritin 30 to 100 micrograms per liter is a symptomatic patient. They often have fatigue, restless leg syndrome, hair loss, brain fog, exercise intolerance, and they should be treated as functional iron deficient. Many of these patients respond clinically to iron repletion despite normal labs, right? In other words, their symptoms improve if we give them high levels of iron, whether that's proper taking pills or an infusion. So the threshold for symptomatic improvement in restless leg syndrome in particular is now generally considered ferritin above 75 to 100. That's a pretty high number considering that 15 to 20 is our low, right? Is the bottom end of our measurement here. That's a big difference. So ferritin in the hundreds with low transferrin saturation, that's the inflammation pattern. And this is the one we want to watch for. The ferritin is in the hundreds. They've got lots of iron storage protein sitting around, but their transferrin saturation is low. And transferrin, remember, is the protein or the partial protein that transfers iron from the ferritin into the cell, particularly the mitochondria and other areas. But that's the inflammation pattern, right? That's exactly what it'll show. It'll show we don't have a lot of iron saturating, but we have a lot of iron in storage. The iron is just sequestered, not absent. That's still effectively iron insufficiency or iron deficiency. Now, ferritin above 300 to 400 in men or above 200 in women, especially with elevated transferrin saturation, raises the question of iron overload. So now we're going the other way. This can be hereditary hemochromatosis, right? There's a gene for that. Thalassemia, particularly in people of Middle Eastern descent. Unfortunately, I think at this day and age, humans have been all over the planet so much that, who is that? All of us. Or chronic transfusion. Sometimes patients get transfusions. Certainly one thing that comes to mind, people are like, why would that happen? Well, athletes like to do this thing where they donate their own blood, store it for a few months in the refrigerator, and then give it to themselves before they're going out to compete. That could be a time and a place that would happen. Oftentimes, though, the patients need further workup. So if you see that, raise the alarm. Now, always pair ferritin with transferrin saturation, or TSAT, and the C-reactive protein measurement. This combination tells the story. Ferritin alone is a little bit ambiguous, right? Again, you could have somebody with a normal CRP and a normal transferrin saturation, and they could be at that, 35 micrograms. They go, boy, is this person on their way to iron deficiency? But in that case, you would say no. But if you see that high CRP, high iron, and low transferrin saturation, that's chronic inflammation. And I'm sure that at this point, you've already figured out what their chronic inflammation is. I just had a patient come in the other day. His chronic inflammation was that he has poorly regulated type 2 diabetes, which is really surprising considering he's on a GLP-1, he's on metformin, but yet his hemoglobin A1C tells the story. It was a 7.9. And that really, it was one of those, what is going on? I mean, I don't understand why I really got on his case. What are your doctors doing? What's going on? Who's paying attention to this? And he says, well, the doctors keep wanting to change my medications, but I don't want to. And then that was one of those, let me explain this to you. You need to listen to your physician in this case. He was contacting the doctor by the end, as he was leaving from the appointment. So thank goodness, right? Okay.
Yes.
So I was
going to say, Neil, what's a recommended ratio between ferritin and transferrin? Does one exist? Like what, you want your ferritin to be around 100 maybe, and your transferrin, does that make sense?
Well, yeah, let me give you the exact saturation.
Just in case people are doing some people take it upon themselves to do their own labs. I think you've mentioned services that do that. And so when they get the results and they need to read it and understand, what am I looking at when it comes to ferritin and transferrin? What kind of ratio should they be looking for? Or
right.
values?
So let's add those numbers. Yeah. Let's add those numbers to what we're talking about here. If the patient's TSAT, right, transferrin saturation levels are below 15 to 20%, that indicates iron deficiency or iron-restricted erythropoiesis, insufficient iron available for the body to make new red blood cells. That's serious anemia. And that's not where most people live, however, because that's, obviously the docs, if they see those numbers, they often respond to those if they've done the TSAT. So a lot of times this is the first time a patient has had the transferrin saturation rate taken is upon, after we suggest it, saying, hey, have you looked at this? Because you have a lot of signs and symptoms that would indicate that maybe you're anemic. The real number we're looking for is about 25% to 40%. That's the optimal range for most adults. And that's, they're always looking at odds of survival, and that's associated with the greatest long-term survival. Okay. Then anything above 45% up to 50%, those are, that's kind of that hemochromatosis we were talking about. So
you might be getting too much iron.
Getting too much iron again. Yes, exactly. Yeah. So that's another, when you see both those numbers, the ferritin and the transferrin saturation rates both high, that's just as much of a medically important thing to refer your patient back to the doctor and make sure the doctor sees those numbers. So, so there you go. There we go. We've added those in. I guess I had not made that. I'll add that to because I do publish these PDFs on my website so that you can actually read through this if you don't want to listen to the whole podcast again. So something for people to go do. Brent, I don't know. Are you posting the PDF on the website or when we do the?
No, but I can. But I can definitely include it in the show notes.
Okay.
Just so that people, normally the show notes just kind of have a summary of what we're talking about and some key takeaways. And then, and then I can add, a link to the PDFs here so that people can read, can do a little more digging and have, it's always nice to have something written out to study.
Exactly. To be able to review and just to, people sometimes want to print that out. My wife, for sure, my wife does that all the time. She goes to websites.
Yeah. I'll get with you about, because this is kind of a recent thing, relatively. So I'll get with you and see with which episode you want to start doing that. We'll go back and take care of the other ones if you want.
Okay, perfect. This one just seems important because, as you know, you had a good question about, well, wait a second, what's the other number we're looking at?
There's a lot of particulars and finesse in this one.
Yes, this one's a little harder, yeah, a little tighter. Okay, so iron and the choroid plexus, the cerebrospinal fluid connection. So now we get to the cranial story. The choroid plexus sits just inside the ventricles of the brain. It's a tuft of vascular epithelium, highly fenestrated, means it looks feather-like, highly feathery capillaries underneath tight junctioned cuboidal cells. Now remember, the tight junction cuboidal cells is that blood-brain barrier. It produces about 500 milliliters of cerebrospinal fluid per day, right? Quite a bit. And the entire cerebrospinal fluid volume, roughly 150 milliliters, turns over 3 to 4 times a day. Okay, that's a lot of fluid turnover. So what does the choroid plexus need to be able to do this, right? How does it, what does it need to be able to produce that cerebrospinal fluid and have it be appropriate? That's really, because if you don't have clean cerebrospinal fluid, one way to think of the cerebrospinal fluid is it's often been given the nickname of the fluid of life, that it actually leaks out through both your cribriform plate in your skull out into the lymphatics of your upper body to kind of be a line of giving the information of health, like how to be healthy. It's a driver of health. And it also leaks out in the lumbar cistern, and actually into the sacrum, out into your pelvic lymphatics as well. So you have these two places. 2/3 of it's leaking out of your skull and into your upper body, down all the way down to your diaphragm. The other third is leaking out of the bottom end of you and then coming up towards the diaphragm. So you're leaking this cerebrospinal fluid into your lymphatics to drive health. That's not a deep scientific way of saying that, but I don't want to get into the whole specifics of that. That's an entire.
I was about to ask you, what does it exactly do? But we'll keep that for another episode.
Yes, that's another. What is the beauty of cerebrospinal fluid?
Yeah, just for a high level, it helps kind of clean things. Like I think you mentioned, right? If it's involved with lymphatics, then it helps kind of pick up waste and clean things out.
Yeah, let me see if there's a quick and easy answer.
And the reason why I bring up that question is, why do we need to be concerned about it? You said that it's the driver of life. Is that what you said? The fluid of life?
It is. The easy answer is that cerebrospinal fluid is a clear, colorless liquid that protects, nourishes, and maintains the central nervous system. And in doing so, right, it's supposed to keep the brain clear of contaminants, of other things that are floating around in our body. And we have lots of those things: immunoglobulins, cytokines. We have proteins from bacterial infections, old ones, broken down cells. We have chemicals that we come in contact with. And that blood-brain barrier is supposed to protect us from any of that stuff getting into the brain, to keep our brain from aging. However, some is going to leach in. And we've shown, research has shown that, for example, some infection into the brain comes in over through the vagus nerve, because the vagus nerve is an end around that blood-brain barrier. But if you're continuously weeping that cerebrospinal fluid, producing and then weeping it out, you're going to take those contaminants right back out of the blood, or the brain case, or the brain area. So you're going to help to keep your brain young much longer and healthy. Now, since it's doing that for the brain, then that's why that's why I say it also leaks out to your lymphatics. And so if it's driving health of the brain, it's also driving health of your body, right? As long as it can stay clean. And that's why we talk about heterochronic parabiosis and some of these other things that become very important, that your blood also be as clean as possible. But the cerebrospinal fluid is the thing that keeps your brain healthy and keeps it nourished.
So in the clinic, when we have someone that it's not flowing properly, they're just not right. I mean, it's bad. And we use our hands to use, manual therapy techniques that help deliver that cerebrospinal fluid and reduce that restriction to it. And the results are dramatic for people. It's amazing. So it's a huge thing that we study in Neil's classes, to be able to use our hands to be able to restore that flow.
Very cool. Right. Is it kind of like a brain fog? Is that kind of like the biggest?
That can be one of the symptoms.
Indicator.
Yes.
But
brain
I mean, it's even just like overall health. Yeah. Sorry.
Exactly. Yeah, so it really connects. It does connect the different brain parts together and allows the neurons to coordinate their efforts. But if that cerebrospinal fluid's not flowing properly, not cleaning out the area, not nourishing properly, you'll get neurons that have to shut down in the middle of you trying to accomplish complex tasks. like scheduling or paying attention to your schedule or driving or so many things. And so that we have somebody that may be a klutz, and it might just be that they're just not getting everything hooked up appropriately. They're not firing their neurons in the order they need to fire to perfectly accomplish a task. They'll be a little jittered on that.
All right. I made a note to maybe prompt you for an episode about cerebral spinal fluid, a little more in depth down the road. I think that would be really fascinating for listeners to understand exactly, what mechanism does it use to help clean the brain or the other parts of the body, and why it's so key for life. So
exactly. Yeah. It's an entire episode all on its own. So that's an important one. I look forward to that one.
Well, maybe even demonstrate how it's done.
Yeah, that'd be great.
That's a great idea.
Some techniques you could show, and that'd be really cool.
So with the choroid plexus, the production facility for the cerebrospinal fluid, what does it need to do its job? Well, it needs very large amounts of energy from ATP in order to be able to drive the sodium-potassium pumps and what we call the apical sodium-potassium chloride co-transporter. That establishes the osmotic gradient pulling water from blood into the ventricle, right? So in other words, you need these pumps that are going to cause water to suck across a semi-permeable membrane. So it's a little bit like your high school chemistry where the teacher had a fish tank and they put a semi-permeable membrane in there with even amounts of water, and they poured salt on one side. And what happened is the salt came over to the side the water came over to the side that had salt in it. Well, this is exactly it, but we're going the other way. So it's reverse osmosis in that we only want clean water and none of the junk. So we have to pump it in actively. So that takes, we need active pumping because the fluid wants to go to all the salty stuff and all the chemicals and everything that's in your bloodstream, not into this very clean, distilled with a little bit of protein in it fluid, right? So you have to drive these pumps. Those pumps require massive amounts of ATP. And now remember, we're producing about 500 milliliters of cerebral spinal fluid a day. That's a lot of pumping, folks. Okay, so then the next one is carbonic anhydrase activity, which is iron independent, but couples to the very same energy demand. And so suffice it to say that what we're doing with that is there are other things we need to pull in to the choroid plexus to make cerebral spinal fluid in the way that it has to be made. There's active aquaporin 1 channels on the apical membrane, meaning the apical membrane is just the membrane in contact with the bloodstream. And we have robust mitochondrial function across the entire epithelium. So lots of energy. Your brain is, it requires a ton of energy just to, keep the environment safe for the brain and clean for the brain, much less for the brain to do its job. The brain can't do its job unless all that goes on. Mitochondrial function in the choroid plexus, like everywhere else, is iron dependent. The FES, the iron sulfur clusters of complex 1, and the heme of complex 4 are not negotiable. When iron is restricted, the mitochondria of these cells run inefficiently. ATP output drops, pump activity drops, cerebral spinal fluid production becomes less responsive to demand. So what does that mean clinically? It means a patient with iron deficiency may have subtle but real changes in their cerebral spinal fluid dynamics, altered production rate, altered pulsatility. Part of how our hormonal states work is that we have these pulses of increase of thyroid, increases in epinephrine, increases in many of your neurotransmitters that help regulate. But even within the brain, we have this cerebral spinal fluid that's supposed to be produced, and then it slowly leaks out, and produced and slowly leaks out. If we lose that pulsatility, and there's just this constant tension, right on the structures, that doesn't work as well as this pulsatile manner. Suffice it to say that part of the efficiency of the function of the system is that it comes in a pulsatile manner. Then you get a slower exchange between the cerebral spinal fluid and the interstitial fluid, right? And the fluid in among the cells, the neurons and the dendrocytes, the other support cells, the brain support cells. And because we now know from Niedergard's work and others that the brain's clearance of metabolic waste happens through the cerebral spinal fluid flow along perivascular spaces during sleep, what we call the glymphatic system. So we know about the glymphatic system, and that occurs during sleep. Anything that compromises cerebrospinal fluid flow ripples into glymphatic clearance and waste removal. Meaning, if you have a day where your brain is really active, the next day you may have, as Brent was talking about, a brain fog or just a lethargy, a difficulty organizing your thoughts because you just didn't remove that waste like you were supposed to at night. And that only comes during deep sleep. So if you don't get proper rest, if you don't have the proper iron, you can see that your brain is not going to function as it should. And you're actually going to age that brain faster because the environment that it's sitting in isn't clean like it's supposed to be. Okay. So very important to maintain iron supplies. So we don't have head-to-head studies showing that iron repletion measurably restores glymphatic flow in humans. No one's really looked at that yet. So that study hasn't been done. What we do have is converging physiology. Choroid plexus needs iron. Glymphatic flow needs cerebrospinal fluid. And the two systems are linked. So we don't have causality there. We haven't done that head-to-head and proven that with hard observation. However, the clinical inference, made carefully, is reasonable that iron status is part of brain clearance health. So it's very important. And it's very important that you do that before you feel like your brain doesn't work. Because I've had patients come to me and say, look, I'm starting to develop Alzheimer's, and I was hoping that there was something that you can help me with. The problem is that a lot of the damage has been done by that point. And it's very hard to slow down and stop that effect. Right. So a lot of what we can do, we can slow a lot of those things down. We can't fix it, but we can slow that down. Unfortunately, it's been going on for so many years that it may be very difficult to slow down or stop. So iron in the cerebrospinal fluid itself, there is a subtler layer here. Iron in the cerebrospinal fluid is normally maintained at very low concentrations, right? We don't want bugs to get in there and have something to eat or to use to grow. In fact, it's in the micromolar range, very, very low, and bound to transferrin and what we call cerebroplasmin. The brain has its own iron regulatory machinery, distinct from the body's, and it protects itself from free iron because free iron is dangerous. Free iron drives Fenton chemistry. It reacts with hydrogen peroxide to generate hydroxyl radicals. We do not want superfree radicals in the brain. So the brain wants to make sure that that Fenton chemistry cannot take place. The most destructive reactive oxygen species in biology, hydroxyl radicals. So very important. That is one of the central mechanisms of ferroapoptosis, iron-driven lipid peroxidation-mediated cell death. In other words, you will lose neurons. Your neurons will die if they come in contact with this iron-driven lipid peroxidation. And that's so you can see that's why your brain's keeping those levels really low. So the brain is always walking this tightrope, right? It needs iron, but free iron is very toxic, and so it compartmentalizes it in every place that it can. Your whole body does that. But if it loses that ability to compartmentalize, but still maintain iron stores, either you have a brain that doesn't work or you have a brain that starts getting burned. It gets destroyed. Okay, so iron and the dura, a living reactive membrane. The dura mater, the tough fibrous membrane that covers your brain and spinal cord, actually covers your nerves as they come out of your spinal cord for a few inches. So that the dura mater is not an inert wrapper that you might think. But you see these diagrams and there's this bag over it and say, okay, nice. That's not what, that's just a bag that it's in. That doesn't have any function. It's actually a highly metabolically active, richly innervated vascular tissue. It has trigeminal afferents, are the source of most migraine pain. Its dural arteries respond to systemic vasoactive signals, right? So that the arteries in the dura mater that are feeding the blood supply to the brain and spinal cord respond to the same signals that the rest of your arterial system does. Its venous sinuses, and we call them sinuses, compartments that hold blood, are the main outflow tract for the brain, right? So we don't really call them veins in the brain. We more call them sinuses because they're very large. Now, where iron interacts with the dural microvasculature relies on heme-based nitric oxide signaling for vasomotor control, right? So back to the nitric oxide. That nitric oxide is how we control the vasomotor, whether we want those arteries more open or more closed. Iron deficiency or dysregulation alters this control, contributing to abnormal dural vascular reactivity, which is precisely the substrate of migraine biology, right? Whenever the doctors talk about migraine, all those medications have to do with helping control the arterial flow of blood into the brain, through the brain. So we will lose that control. So if patients with migraines, one of the very first things we want to do is we want to go back and do all these tests and look at that and say, Can we ensure that are we ensuring that this patient has the correct amount of iron in their brain to function? Or do they have too much? Again, back to those tests. That's why you test. You have got to look and see. We need to know. We need to know. We can't be guessing, going, oh, well, I think maybe that. I want to know. I want to see the numbers, and we want to measure them. Because again, it could be either side of the equation and go, excessive iron is just as bad as not enough iron. Now, dural macrophages, mast cells, and resident immune cells use iron in their respiratory bursts and inflammatory processes. Iron-restricted inflammation behaves differently than iron-replete inflammation. And chronic neuroinflammation, increasingly implicated in headache disorders, post-concussion syndromes, and chronic pain, and damage to the microvasculature is where we're actually understanding more that now that more stroke is actually due to microvascular damage. And that by the time we find the microvascular damage, it has now begun to affect larger vasculature, right? So we've always thought in the past that strokes are because of large vasculature problems. What we're seeing is that actually the damage is down at the microvasculature, in other words, the capillaries, and that travels on either side of the capillaries to the venous or the arterial side and goes backwards from that microvasculature out to the larger arterioles or venules. And that's where stroke is really coming from. So again, back to this, your immune system, your dural macrophages, mast cells, and resident immune cells, they use iron in their respiratory bursts and inflammatory responses. And remember, acute inflammation is actually good. It's healing. It's immunity, is response to activity. It's growth, but it has to turn off, right? So all that, but if we get chronic inflammation, particularly chronic neuroinflammation, that is breakdown of the whole system. That's breakdown of the brain. So all that is an iron handling component. Very important that we know those numbers. Iron deposition itself can occur in the dura and surrounding tissues from subarachnoid hemorrhage, right? So there are actually 3 layers to the dura mater. So there's the area that we call the subarachnoid space, where if an artery breaks, that's where a subarachnoid hemorrhage will be. It'll be in between the outermost covering and then below the inner 2, or in between the inner 2 layers of that dura mater. And that's where people get those bruising they will get like a bruise or whatever on the head after a concussion or a blow to the head. They might get repeated microbleeds, right, from repeated trauma. I mean, the most classic for this is boxers, right? I mean, think of Muhammad Ali and a lot of those repeated microbleeds, small blows to the head repetitively, not small for him, but repetitive blows. So you get repeated microbleeds or chronic inflammation. So there's hemosiderin staining is a marker of past bleeding and active local oxidative stress. And when they go back and look at brains, in pathological report after someone's passed away, particularly for what we call a CTE, right? For football players, soccer players, this, that, the other, some of those athletes are having their brains examined after they've passed away to determine that. Well, we use this stain, hemosiderin, to see, have they had past bleeds? And that's chronic traumatic encephalitis. It's like, right, you get chronic inflammation in the brain because excessive iron causes inflammation and breakdown of neurons. So what I want clinicians to really take away here is that the patient with chronic head pressure, tension headaches, post-concussion syndromes, or migraines, if their ferritin is sitting at 18, their dura is operating in a metabolically and vascularly compromised state because they cannot control the diameter of their arteries. They can't make them responsive. So they can't get blood when they need it, and they can't keep it out when they don't need it. That's a problem. That's an injury. So restoring it is part of what makes the system more resilient, right? We have to restore the appropriate iron levels. So you can do all the cranial work you want, and you're not going to help the patient as much as you might like to, because they don't have the appropriate amount of iron. So for those people who did take our Arbuckles courses or do cranial work on patients, and you're just wondering why you're not getting success, this is a key component of it, of really being tight about what's their iron level. So let's talk about iron and the autonomic brainstem, right? That's a component of what we're talking about here. So here's where the OsteoSignal listener should sit up and take notice. The brainstem nuclei that run autonomic regulation are some of the most iron-dense regions of the brain, okay? So remember that the brainstem nuclei are implicated in Parkinsonism, right? And there's a whole group of neurological problems that are related to these brainstem nuclei. And then they all have a bunch of different names. Parkinsonism is the most easily noticed by most people. Aphatism, Ballism. There's a whole list of them. But in inappropriate sleep-wake cycles, you have people who can't go to sleep. Anyway, so specifically, the locus coeruleus, the principal source of central noradrenergic, containing some of the highest iron concentrations in the brain, its neurons synthesize norepinephrine, right? Or norepinephrine, a step that requires iron at multiple points, tyrosine hydroxylase, dopamine beta hydroxylase, indirectly through copper, but coupled to iron. So your sleep-wake cycles, your stimulation, like people say this all the time, like, oh, something's going on. And I'm just lethargic. I don't get excited about things. So your activity level, your activation level will be hampered. Now the substantia nigra, the dopamine engine of the basal ganglia, also iron dense. So here's what we're talking about, Parkinsonism. The brain iron in the substantia nigra increases with age and rises pathologically in Parkinson's disease. There we go. Nucleus tractus solitarius, can you say vagus? The vagal sensory hub. It integrates cardiovascular, respiratory, gut, and immune afferent. So all this information is coming into that area. All that information has to be integrated and coordinated, and iron-dependent enzymatic machinery here supports both signal processing, so understanding what those signals are, putting them together, but also neurotransmitter synthesis. Can the vagus be activated? Can it release neurotransmitter?
And just a reminder, an afferent is something that takes information from the extremities and brings it into the central nervous system. Just wanted to...
Exactly. Afferent is sensory.
Yeah. Okay. Thank you.
Now the dorsal motor nucleus, now that one's motor, obviously, the parasympathetic outflow to most of the viscera. So so many people are doing these things to try and increase their vagal tone. Well, that vagal tone is produced at the dorsal motor nucleus at the base of the skull, right? In the upper cervical and the base of the skull. So you can obviously see what a manual therapist is going to be very interested in how that area works. I think there are a lot of practitioners interested in how well that area works. But your vagus nerve and your other parasympathetics cannot cause the rest of the body to function properly if that area is not getting the right signals. Then there's some other basal ganglia, globus pallidus, red nucleus, and the dentate nucleus. They're coordinate motor function. They're all highly iron rich. The red nucleus is red because of iron, somewhat like Mars, right? Mars is the red planet. Well, it's red because of iron, has lots of iron on its surface. Well, all those three centers help coordinate motor responses. So somebody who's all of a sudden becomes clumsy or has gotten clumsier with age or through some period of time, gosh, I just feel like I'm out of sorts. I drop my coffee cup. I miss it. I go to reach something and I hit my hand on something. I hurt my hand. That can be iron deficiency. So the brainstem nuclei that control your heart rate, your gut, your breath, your sympathetic parasympathetic balance, and your stress response are running on iron. When iron supply is restricted, even subclinically, these nuclei don't fail loudly. They drift. They become noisy. They lose precision. So the clinical picture, a patient with low or low normal ferritin and autonomic complaints, lightheadedness on standing, okay, so our POTS patients, palpitations, right? Chest palpitations, cold intolerance, anxiety, poor sleep, restless legs, exercise intolerance, postural orthostatic tachycardia features, POTS, is a patient in whom iron status almost always deserves a careful look. Restless leg syndrome is the cleanest example of this. And I know we've talked about this in other podcasts, but it bears repeating. Brain iron deficiency, often with normal or near normal serum iron, is now considered the central pathophysiology of restless leg syndrome. And ferritin above 75 is the general therapeutic target. Some even say 100. That same brain iron deficiency drives changes in dopamine signaling and circadian regulation that ripple into sleep architecture, mood, and cognition. And let's say it again, sleep architecture. How much deep restorative sleep do you get? That is the time when your glymphatic system can be active. So not only do you get fractionated sleep for sleep architecture, so that you get that deep sleep to lymphatically clean out your brain, you also don't have the ability to clean out your brain because you don't have the right amount of iron in there. So you can just see how this is going to lead to an environment that is not supportive of brain health. And that, and oftentimes these patients are in our clinic asking for help because everyone else has looked at them and said, we can't find anything wrong. So, I understand and respect your skills. And when you're not getting changes like you think you should, look deeper. I see this every week in my clinic, right? Patients have been told their labs are fine because hemoglobin is 13 and ferritin is 22. It's the patient who's exhausted, foggy, restless at night, and they complain, I'm always tired, I can't get a good sleep, I wake up all the time, and whose autonomic regulation is on the floor. Repleting iron or bringing their iron stores back up when appropriate can change that picture more than any manual technique I could apply, because I can't make iron be there if it's not there. It's a huge problem. So let's go into that a little deeper. Iron, sleep, and the glymphatic loop. I've already kind of presaged this, but let's talk about it. So the last episode, I made the case that slow wave sleep is where the brain's waste clearance system runs at full power. Actually, it was a couple episodes ago. Glymphatic flow rises roughly 20-fold in deep sleep. That 20-fold. So it's always running in the background at a low level, but in deep sleep, it's 20 times higher, highly restorative, really cleaning out the brain. Cerebrospinal fluid production must be adequate, right? So if you're glymphatically clearing and taking all the gunk out from in between the neurons and the support cells, you're dumping it somewhere. Well, where are you dumping it? Well, into the cerebrospinal fluid. Well, are you getting that cerebrospinal fluid out of there and then bringing new, fresh, clean stuff in? Or are you just letting that circulate around the brain? Okay. So the cerebrospinal fluid production must be adequate. Vasomotor pulsation must be intact. Aquaporin 4 must be in place at astrocyte end feet. Now, astrocytes are support cells, oligodendrocytes and astrocytes are those support cells for neurons. And right here is right where the place where head injuries and those we see with people with head injuries, they have 20-minute periods of time when they can be active and do stuff and concentrate. And then all of a sudden they're done, right? Well, guess what? That's because the support cells, the astrocytes and the oligodendrocytes, can't bring fresh materials in quickly enough to meet the needs of the neurons when the neurons are operating at high level. So then the system has to shut down. And so that's why we oftentimes take that person with a head injury, we put them in a darkened room, let them, close their eyes, no stimulation, because we have to let these systems catch up. And it's going to take, for 20 minutes of activity, it can take 40 minutes to an hour to catch up with that much activity. That's not how the brain's supposed to work. And all of that depends on how a brain that's metabolically and ionically competent. The brain has to have the constituents to do its job. And if we're not looking at that, if we're not feeling that with our hands and understanding that, gosh, this person has headaches, has these problems, has this brain fog, and the suboccipital muscles, the muscles about their skull, or even doing our mobilization, our cranial mobilization, just doesn't get the effect that we want. This is what I want you to think about first thing. So let's specifically speak to how does iron tie into this? Dopamine has a strong circadian and sleep regulatory role. Iron is required for dopamine synthesis. So the first thing your patient says, can't sleep. Already you're going, what? Iron deficient patients fragment sleep in part because the dopaminergic systems that quiet motor activity at night are not working at full capacity. So you can see how if it goes too far, it becomes Parkinsonism because your body, that's where the tremors or the cogwheel, the rigidity, some of these other things that you see, the brain is not able to properly control muscle activity. And that's where, that's where Parkinsonism is. But at a lower level, that's where iron deficiency is. You stop having that proper control. You can't keep your body quiet at night, like restless leg syndrome. People who twitch a lot at night. This is something that, gosh, yeah, I wake my partner up all the time. And they're always saying that I've smacked them in the middle of the night. And that's because, here may be an answer as to why they do that.
So is Parkinsonism kind of like because they have maybe too much iron and they stop, their muscle control goes the other way? It's not restless, which is a deficiency, but it's the opposite side of the spectrum where they just can't, they can't control their movements because there's maybe too much iron.
There are not Parkinson's per se. There are some other ones. This is a classic example in biology where if you go out of there's the range where something's supposed to work. And if you go out either side, things stop working in a similar fashion. Now, Parkinsonism.
You can have similar effects.
Similar effect. Yeah, it'll look very similar. A high blood sugar and a low blood sugar have some similar effects. That there's other things that are very specific to them, like a low blood sugar does one thing and high blood sugar does another. But when you're looking at them, there's a lot of similar mental effects, emotional effects. It changes the brain and how it works similarly until you get far enough out there, and then it becomes more obvious. But so yeah, anytime you're out of the range either side, you get a similar effects. It's hard to ferret that out sometimes.
Okay, I just wanted to bring that up just to kind of contrast what low iron
but
would
to
look
speak
like
to that a little bit.
Yeah. High iron.
So Parkinson's, we've actually learned some more stuff about it. There are those people who they don't have enough dopamine. They're not able to make dopamine. And that would speak exactly to what we're talking about here. Then there are those people who make dopamine, but they can't respond to it appropriately. And that would be, so the problems occur in slightly different places, but they'll look very similar, right? Because it's hard to tell one form of Parkinson's from another form. There are those people that they take L-Dopa as a supplement, and that helps tremendously. And other patients take L-Dopa, and it doesn't help at all. And you go, wait, what's the difference? Some people have Parkinson's because they don't have enough dopamine. Some patients have Parkinson's because they can't respond to the dopamine any longer. And we covered this, a similar thing with the adrenaline, and that adrenal fatigue is not necessarily that you don't have adrenaline. There are those people. It's that your body has stopped being able to respond to the adrenaline, right? And so that does kind of speak to what you're talking about, that there's lots of little nuances as to how this happens. Again, this is why we do labs, and we have to know, we have to measure.
Awesome. Thank you.
Yeah, hopefully that speaks to that.
It does.
So the choroid plexus, as we said, runs on iron-dependent mitochondrial function, right? Cerebrospinal fluid supply for nighttime glymphatic flow depends on healthy choroid plexus function. Fragmented sleep then drives further inflammation, which raises hepcidin, that restricts iron utilization. And we get into this vicious loop where the neuroinflammation makes it even worse, that we can't get iron. We can get iron even less. So it really becomes a problem. So a patient with iron deficiency who isn't sleeping well isn't just tired. They are running a brain that didn't get its nightly clean. Over weeks, that's uncomfortable. Over years, it's a risk factor. We just did a podcast the other day where we were talking about the microenvironment, or the niche environment inside of bones, and how that pre-selected for cancer cells, particularly mesenchymal stromal cells. I think what we're going to do is we're going to see a very similar thing in the brain, right? That if the brain environment is that off, what's going to happen is the chemistry changes, and it's going to select for inappropriate cells as opposed to selecting for healthy, normal cells. Again, we're extrapolating here, but that's one of the things we do in medicine is we start extrapolating information. Well, wait a second. And that's why we say over years, iron deficiency becomes a risk factor, that it's leading to a niche environment that isn't properly maintained. That's not going to go well. Can lead us to the doorstep of many other disease processes. So not sleeping is not just being tired. In the iron-restricted brain, it's skipped maintenance or deferred maintenance. And that's not a good thing, right? Deferred maintenance is always bad. Okay, so let's address this issue. The iron paradox, deficiency and overload. And I want to spend some time here because the conversation about iron in clinical practice is usually one-sided. Mainstream medicine tends to overlook subclinical deficiency. Functional medicine tends to overcorrect into supplementation. Both miss something important. Iron deficiency, common causes that I see in adults. Heavy menstrual bleeding, obviously, by far the most common cause in premenopausal women, often unrecognized as normal for me. And I've had these patients, and, unfortunately, sometimes taking iron pills, it just causes lots of constipation and it doesn't absorb appropriately. Some people can take iron pills and they do great with it. I have a lot of patients, and for whatever reason, and I have an idea, women who have heavy menstrual bleeding also tend to have hind gut problems, meaning that the iron causes an even bigger problem in their system. So they tend to stop taking the iron pills. Well, it's not very effective if you don't take them. So there are various things we have to do about that. And education is the primary thing. Pregnancy and postpartum. The demand outstrips intake. Many women are still iron depleted a year out. And we talked about this when we were talking about the placenta. Low iron levels and postpartum depression are intricately entwined. There's no way. And we should be, women take those prenatal vitamins. And I don't know, Autumn, you'll have to speak to this. Do women stop taking those because they've been told to stop taking them by their doctor? Do they stop taking those because they're pregnant and that causes them to get constipated? I don't know, because certainly the supplementation has to continue.
Yes, I think what I see when women that have had a baby that haven't remineralized in between is they just think, well, I'm not pregnant anymore. Why would I take him? So that's over. It's it's kind of a routine thing, kind of like drinking water. If you're out of the habit or you're out of the routine, then and once you've had the baby, your whole life goes upside down, and you think, oh well, I don't have these restrictions anymore. Babies, I'm handling it this way, so you don't take it anymore because you're thinking that phase of my life is over. Now I'm in
Yeah,
this new stage.
mission accomplished.
Right. Yeah. And then no one's educating the patient immediately. And I have to say, this is all kind of new information as well for me, that we've kind of come to these conclusions going, oh my gosh, I didn't recognize that before this. But I think we all, in our group now recognize this, going, oh my gosh, I can't believe how important this is. Okay, awesome. Okay, chronic GI blood loss. Gosh, I just had this patient too her doctor says no, her naturopath says no. Yes, you have iron deficiency. So there's a thing that we call NSAID gastropathy, right? People who bleed because they're taking NSAIDs. Peptic ulcers, hemorrhoids, undiagnosed colon cancer. I have a patient. That's how she got diagnosed. Always rule this out in a man or postmenopausal woman with new iron deficiency. Always. So if iron deficiency all of a sudden pops up and they haven't had that, this is important. Malabsorption, right? Celiac disease, H. pylori, gastritis, atrophic gastritis, post-bariatric surgery, low gastric acid. So proton pump inhibitor people, the Nexium, the Prilosec, and people will go on that. For example, this patient I was just talking about, she had 2 ulcers that, few inches apart in her intestinal tract. And so she, of course, couldn't take NSAIDs. They had her on a proton pump inhibitor to help them heal, and they healed. But what we saw was that, and so of course that causes malabsorption, right? She has blood leaking into her GI tract. So then she can't absorb not just iron, but a lot of the nutrients. But of course the doctor's response was, oh, we'll just eat right and you'll gain this all back. It's like your stomach, even though you've stopped bleeding and the ulcers look healed, doesn't mean that your intestinal tract automatically kicks back in and starts absorbing everything. There's still chronic inflammation in that. And again, once this process gets started, you have to turn it around. I mean, in this case, I do visceral manipulation. I have to get her esophagus to work properly. I have to get her stomach and her duodenum to work properly. We're trying to bring that system back online and get that inflammation out of there. At the same time, she needs iron. And so the easiest way for me and the best way I would have suggested to her, saying, if you try to put it into your gastrointestinal tract, you're probably not going to get it. So you have a malabsorption aspect of this that you can't absorb. So telling somebody to eat their leafy greens or to do this or do that, and not tell them, look, an infusion at least gets us up and running for now, and then we can try that other form. But that's a problem as far as I'm concerned. But
yeah, I see that a lot
vegan
too.
Diets.
Yeah. Yes. I was just going to say that. Yeah, but a lot of them are taking iron supplements, but they're like, well, it's kind of like, pitching a jelly bean into a black hole. It's not going to do anything. You gotta hit it really hard first, and then give it a chance to come back online, and then it'll start to work again. That's what we see a lot of times.
Yeah. So the vegetarian and vegan diets without careful planning, non-heme iron is far less bioavailable than heme iron, unfortunately. And heme iron tends to come in red meat. So I had a patient, she and a lot of people do this. They might be vegan for a while, then they kind of go back to vegetarianism. But this lady had such bad anemia that she goes, well, I do like the flavor of a good steak. I was like, I'm sorry, but the best thing you could do is eat a steak, because that is much more available. If you refuse to get an iron infusion, which she didn't want to do. In fact, this was probably about 10 years ago. Iron infusion has become much more available, it seems to me. Still expensive, can be, but more available at least. which I think will bring the price down. Okay, so our other person that we've talked about in the podcast, high volume endurance athletes, a combination of foot strike hemolysis, GI losses, right? Because their food just shoots through them, so it also tends to beat up their GI tract. Hepcidin elevation from exercise-induced inflammation, and increased turnover, cellular turnover, et cetera, et cetera. So they just can't hold on to their iron. Now, the symptoms of iron deficiency, the under-recognized list, right? Fatigue, of course, but also exercise intolerance disproportionate to fitness, restless lights at night, brain fog, or word retrieval. I have a patient right now. She keeps going, she has the clinical name for her. I can't think of it offhand. She's always saying it. She goes, oh yeah, I can't
You're
remember
having
the
a word
words.
retrieval issue.
I'm having a word. Maybe I better check my iron right now. Hair shedding, excessive hair shedding, often the first complaint, often dismissed. Brittle, spoon-shaped nails, right? So the fingernails will be spoon-shaped. There's a number of things that can cause that, but iron deficiency is, cardiac insufficiency is another one. So you can see that those are related. So iron deficiency, brittle, spoon-shaped nails, a smooth, sore tongue, right? So if the tongue loses its rough patches, but is sore, we call it atrophic glossitis. Pica, the craving to eat ice, dirt, or starch. People eat some odd things, so it's called pica. Shortness of breath on exertion, headaches, anxiety, palpitations, and postural dizziness. Cold intolerance, especially in the extremities. Okay, so that hopefully, and we keep going over this list and keep saying this stuff, and hopefully we're all getting that in our head and going, if you hear these, you'll go, oh, wait. Because the whole pica thing, I've had a patient who came in and she was saying, I have such a craving to eat this dirt. I didn't know that could indicate iron deficiency. Iron overload. On the other side, hereditary hemochromatosis is more common than people realize. Roughly 1 in 200 Northern Europeans is homozygous for the C282Y HFE mutation. Not that we need to know that one. Most won't develop clinically significant overload, but those who do develop it slowly. Fatigue, paradoxically similar to deficiency, like we were talking about with Brent, how if you're outside the range on either side, things often look, the body has a similar response initially. Arthralgias, people coming in complaining of joint pain. And of course, that's us. We have people coming in complaining of that all the time. So classically, the second and third metacarpal phalangeal joints, their fingers, and they'll say, oh, and they may even be enlarged. Elevated liver enzymes. Okay, that's not the one you always think of, but elevated liver enzymes, hyperpigmentation, diabetes, and they get the bronze diabetes where they're darker, their skin is just darkened. We also blame it on high sympathetic tone, which chronic high sympathetic tone is also a symptom of iron deficiency, and cardiomyopathy, right? So abnormal heart function. So remember, the labs to get ferritin and transferrin saturation, a TSAT above 45% in men or 35% in women with elevated ferritin warrants testing for hemochromatosis. If it's, when we say below, if it's 15%, we know that this person has iron deficiency. If it's in that 45% or 35%, we know that they're going the other way. So, okay. Now, remember that iron is selectively toxic to certain brain regions when it accumulates. Brain iron rises with age in everyone. It rises faster and pathologically in Parkinson's disease. So there is iron deposition in the substantia nigra. It's one of the earliest imaging findings. Alzheimer's disease. Iron co-deposits with amyloid plaques and contributes to oxidative stress. Multiple sclerosis. Iron deposition around chronic active lesions. And Friedreich's ataxia and severe rare neurodegenerative syndromes. So there you go. Brent's going, yes, I knew it. Susceptibility.
So it's not necessarily having too much iron. It's just where it ends up.
Yeah. It's not that you have too much iron. It's that that your iron metabolism is inappropriate.
Yeah.
And so again,
it's getting used inappropriately.
Getting used inappropriately. And so this is why we have to test. I do have a few patients I say, well, we need to test this. And they're so resistant to testing. It's like, I can't tell you what the problems are if we don't look. It's not improved by a system that doesn't like to, that there's foot dragging in the system as well. Oh, I got to go to the doctor. I got to get this ordered. I want my insurance to pay for it. They should pay for it. The doctor didn't want to order it. They didn't want to do the extra ferritin. They didn't think I needed a transferrin saturation. And so you could pay that out of pocket, but a lot of times people are like, hey, I have health insurance. I want that to pay for it.
Yeah, and I think sometimes people just don't want to know either. They're just like, if I don't,
yeah.
There's some kind of mental, if I don't get this result, then I don't have to worry about it. So I think that might be
right. The ostrich syndrome.
Part of it too.
Just stick my head in the sand. Yeah.
Right.
That's a great point. I do think that's very, very true. Susceptibility weighted MRI imaging now visualizes this directly, but you have to get an MRI, which is expensive, and you have to go to the doctor. Brain iron is quietly becoming one of the most important biomarkers in neurology. Okay, so the clinical principle here, iron is Goldilocks. Not enough, the system runs starved. Too much, especially in the wrong compartments, and it drives oxidative damage and ferroptosis, meaning destruction. The clinical job is not more iron or less iron. It's the right iron in the right place. Being able to move iron in and being able to move iron out. So that's where osteopathic manual therapy comes in, that is understanding this and helping these areas work. And like Autumn was alluding to, in class, we do Arbuckle's approach to cranial manipulation. And that much more functions with the dura, which is the dura is ultimately there's a certain movement of the brain case and that dura that helps pump cerebrospinal fluid. And that's what we want. Appropriate movement of fluid, appropriate constituency of the fluid, and the ability of the body to adapt and respond to changing environments. And especially as people age, they've accumulated, people always say, this is because I'm old. It's not because you're old. It's because you've been exposed more. And so there are people who expose themselves at high rates more quickly, right? Boxer, like our example was the boxer who's taken a lot of head injury, but everybody falls or hits their head here and there. And given enough time, you've accumulated a lot of damage over time that has to be addressed. Otherwise, we see these devastating diagnoses start coming up. So practically, don't supplement empirically. Test. Treat the deficit, monitor the response, and stop when the targets are met. That doesn't mean stop taking iron entirely, because so you do have to watch over time. Does the patient continue, like once they've gotten their iron stores back up there, are they able to get it in their diet? Because sometimes just getting people back on track, their body can take back over and they do really well. But every once in a while, you have to go back and say, let's at least test. So ideally, yearly test.
Usually when I have a patient that had to go get an infusion, after one or two, they're on their own. They can take oral or something like that, and they're going to be okay. I don't see too many people that have had to have it once that have to have that as like a lifelong, lifestyle change.
Yeah, exactly.
So,
yeah, it's often linked to past menstrual cycles, or if they're postmenopausal, for childbearing or childbirthing, right? Or they went through a very stressful time. Maybe they had an ulcer. Didn't get diagnosed, but now that they're back on track, now they're back where they belong. So, exactly. Okay, so the OsteoSignal lens, where do the hands fit in, right? Now, from the manual therapy side of this, we talked about this a little bit. I'm not going to claim that osteopathic treatment fixes iron deficiency. It doesn't. A patient who is iron deficient needs a careful workout, oral or IV iron repletion as appropriate, and a search for the cause of the loss. Like the patient, she ended up getting an endoscopy because she just wasn't doing well. I said, there's something really wrong. I'm not getting you better. You're really fatigued. And she goes, well, who should I go see? And just because of her recent past, she had an infection in Guatemala. I said, well, let's send you to the ENT. Let's see if they can look through some of this and figure out what's going on. And that's where she had the endoscopy, found the two ulcers. We have to get to the bottom of these because we need to know what are the causes. Now, she had a follow-up endoscopy 8 weeks later after the proton pump inhibitor, and they had healed. Perfect. But now you got to do the iron, and she still hasn't done the iron. Yeah, it's problematic. And then she can't, partially because of the medical siloing of care. The ENT saw this, but didn't say you need to go, you have a IV. That doc said, hey, I helped with the ulcers. I did my part. Go see your primary, go see somebody else for this. And you're like, and I'm not blaming that doctor. I'm saying, hey, the doctor did a great job. I'm certainly telling the patient, but she's dragging her feet. She's going, well, I don't know. It's like, I don't know that I have that. It's like, lady, I'm telling you, you have this. And unfortunately, the system is saying, oh, gee, clear down at 15. You're still kind of, and she's an 18. She's at 18. And you're going, this is classic. But
Well,
Okay,
this is
so
what I love about why you're doing this is because it's not just iron. It's not like filling up a gas tank and then it's there and the body's going to use it. It has to be able to be sensitive enough. It has to be able to use it. Has to be able to do these different things. And so that's what I love about what you're doing by explaining all this stuff because we don't have this kind of time in the clinic. And if people can kind of understand that and be like, okay, it's not just this. It's also vitamin C. It's also these other things that we have to monitor and then help. And if the patient knows that or the client knows that, consumer of the medical system, right? Then they can help the doctor go, okay, now what about this stuff? Because I know that these work together. So what are we gonna do about that? And it just helps. It just helps.
right,
So
right,
yeah.
right. And you give people information, and if they don't take it up,
Yeah. They have
then
the
they don't
choices.
take it up.
Yeah.
Right. They have choices. So what manual care does is it works alongside that medical care to optimize a system that the iron depends on, right? We make the systems work better so that when there is iron there, they can make use of it. There are 5 places this matters the most, right? We already talked about this. The cervical cranial venous corridor. The cerebral venous outflow runs through the jugular foramen and the base of the skull, the internal jugular veins, the vertebral plexus, and the deep cervical lymphatics. So those areas have to work. Restriction at the suboccipital triangle, the upper cervical fascia, the carotid sheath, the thoracic inlet that slows that outflow. Those are all problems. In a brain already running on tight metabolic margins because iron is short, venous congestion compounds the problem. Opening that corridor reduces one of the background loads the brain is fighting. So, number 2, the diaphragm and the respiratory pump. Diaphragmatic excursion drives venous return, lymphatic propulsion, and the slow respiratory modulation of intracranial pressure that contributes to lymphatic flow. A restricted diaphragm degrades all 3. We work the diaphragm not as a muscle, but as a system pump. In autonomic balance, iron deficient patients run sympathetically dominant. Their resting heart rate is higher, their HRV is lower, and they are more reactive. Manual work that generally shifts vagal tone, OA decompression, suboccipital release, gentle thoracolumbar work that calms T9 through L1 facilitation particularly, but also T1 through L2 as an overall view, gives the autonomic system room to settle. As iron repletes, and that is the iron levels come back, this settling becomes more durable, right? So this is care that has to be ongoing throughout this process as the iron, not only as the patient is taking the iron, but as their body is taking that up and replenishing itself, healing, going through that whole process. We have to keep going through that system to help bring that system along because the system can't function as it should. It has broken down and gotten into kind of a locked, aberrant response system. The visceral and the gut interface, right? Iron absorption happens in the duodenum and proximal jejunum, right? So right in that small intestine. It depends on adequate gastric acid, right? So those proton pump inhibitor people, like, look, you can't take those for life. Otherwise, you can't break down iron to make it absorbable, right? Just like this patient and her PPI is like, yeah, that helps you heal the ulcer. So we've done that medically. Her doctor did say, okay, you can stop that, which was great. But I've had other patients come in going, oh yeah, just have me on it forever. It's like, well, you're iron deficient here. So you need adequate gastric acid, healthy mucosa, and unobstructed transit. So if they have transmission problems, in other words, they're constipated, that's problematic because then that means that inflammation sits there and then that inflammation raises the hepcidin, makes it so they won't absorb, blah, 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 right? Back to what we were talking about then. Yeah, but the mucosa has to be healthy. Somebody has to be working on the gut itself to make that work or to get that inflammation out of the gut so it can absorb iron. Combined with vagal tone improvements, because vagal output drives gastric acid and motility, we improve the gut side of the iron equation. Not a cure, but certainly a contributor in making the body responsive. And then the cranial work itself, without overclaiming the primary respiratory mechanism, careful cranial work influences dural mobility, right? I don't want to make overclaims here, but the primary respiratory mechanism is the drive, the brainstem, telling the body to breathe. That's the primary respiratory mechanism. If that doesn't work properly, you don't breathe like you should, or as often as you should. So careful cranial work influences dural mobility, venous outflow, and the mechanical environment of the cranial nerves. In patients with chronic head pressure, migraine, or post-concussion symptoms, in whom iron status is also compromised, cranial work can soften the symptom load while the metabolic work catches up, but it can't replace it. So there are a lot of people coming in for headaches and migraines, and you can do all the cranial work you want. It's not going to change things. And that certainly should be a signal to you as a practitioner or as a patient that you need to look at your iron. Okay, so the statement would be, you can't replace iron with the hands, but you can give the iron restored brain a better mechanical environment to live in and to work in. Okay, what I order on a patient, not that I ordered, I asked them to talk to the doc, but what I order on a patient where I suspect iron is part of the picture: CBC with a peripheral smear, ferritin, iron, total iron binding capacity, transferrin saturation, reticulocyte count, right, cell count, C-reactive protein to interpret the ferritin. Like, is the ferritin high and normal, or is the ferritin high because of chronic inflammation? Vitamin B12 and folate, because they often co-occur. Deficiencies in those often co-occur with deficiencies in iron. Thyroid stimulating hormone and free T4, because thyroid dysfunction overlaps symptomatically and pathophysiologically. Comprehensive metabolic panel. And if indicated, tissue transglutamase, IgA for celiac disease, H. pylori workup, right? See if they're off-gassing. Fecal occult blood, doing a guaiac test is called. It's also been called a test for blood in the stool. A GYN gynecological consult for menstrual loss. Definitely have those patients come and say, I've been bleeding for 48 days. Oh my God. Make sure they're getting that addressed, of course. And then repletion principles. So let's talk about what would be the medical management. It's medical management, but worth knowing. We need to understand this because we're the ones that help follow the patient. Oral iron is first line for most patients with mild to moderate deficiency. Certainly. Recent evidence supports every other day dosing of 60 to 120 milligrams of elemental iron taken on an empty stomach with vitamin C to maximize absorption and minimize hepcidin spikes that suppress further uptake. Some people tolerate that, some people don't. So that's certainly what you have to ask them. Don't take iron when you're ingesting coffee, tea, calcium, dairy, or antacids, right? Back to the antacid, you have to have the appropriate acid to break down and make the iron absorb. All of those, coffee, tea, calcium, dairy, and antacids, markedly reduce absorption of iron. Okay? IV iron is one thing that can be done. Ferric carboxymaltose, ferric, these are the ones. Ferric derisomaltose is appropriate for severe deficiency, malabsorption, intolerance to oral iron, or patients unlikely to absorb adequately, chronic inflammatory patients. Modern formulations are well tolerated and rapidly effective. I still have some patients who say 30 to 60 days to see it really come back, but that's fairly fast, as opposed to sometime next year, you should feel better. Nobody wants to go through the whole year again not feeling well. And
especially
then again,
we
treat
can
to the
be
target.
so depleted for so many years. So that's not too bad.
Right. Well, and as we start if we're working on them while they're going through this repletion, it makes them use their iron better, but it does get it deeper into so they're still going to they're still going to be deficient because we're making sure that all the tissues are getting the iron that it needs, because this deficiency has gone through this entire body. And it's almost like trying to start an old car that hasn't started in 30 years. You really have to bring that system back on. Remember, treat to target. Ferritin above 50 minimum, often 75 to 100 in symptomatic patients. If the patient's at 18 and you get them to 30 and you go, oh, we're at 30, that's it. Doc said I don't have to do it anymore. That's not enough. And certainly if they have restless leg syndrome. Recheck at 8 to 12 weeks. So by 8 to 12 weeks, we would expect changes. Always identify and treat the underlying cause of loss. Don't just refill a leaking tank. Sometimes that can be hard. Referring this one patient to the ENT who just happened to get lucky because I did have some idea that that's where she had a problem. So that was good to have, because then we had something else to measure, go back, look at, and then say, okay, now we can move on. Okay, red flags: refer, don't treat. New onset iron deficiency in any adult man or postmenopausal woman. GI workup for occult malignancy is mandatory. That may be the very first sign that they have colon cancer or prostate cancer. Iron overload pattern: high ferritin, high transferrin saturation, hepatology, and HFE testing for hemochromatosis. Severe anemia, hemoglobin less than 8 or symptomatic. If they're less than 8, they should be going to the emergency department or urgent medical evaluation. That person probably needs a transfusion. So if you ever tell the patient, don't come to my office, go straight to the doctor now. Ideally, the one at the emergency department. Iron deficiency with neurologic symptoms beyond fatigue, such as numbness, ataxia, cognitive decline, needs neurological workup, including B12, copper, and appropriate imaging for iron deposition. Pica with neurologic symptoms in children. Lead exposure must be considered alongside iron deficiency. So children eating dirt or if they're eating things that just seem inappropriate, saying, okay, this kid may have been exposed to lead. Okay, let's put it all together. Let me bring this back to one patient because that's how I think about it. Imagine a 38-year-old woman, 2 kids, heavy periods, runs 3 days a week, drinks 3 cups of coffee a day. She's tired all the time. She wakes up at about 3 a.m. Her legs twitch before bed. She started forgetting words. Her doctor ordered a CBC hemoglobin, 12.8, mean corpuscular volume, 85. Normal, right? She's normal. You're fine. She's not fine. That's the problem. So you got a ferritin test, 14. Thyroid stimulating, transferrin saturation, 8%. CRP, low. So that's just iron deficiency without anemia, right? She's not anemic, but she's certainly iron deficient. And the story explains itself. Yeah, the choroid, plexus, mitochondria are running short, right? And that's the brain stuff. She keeps forgetting words. She walks into a room. I can't remember why I'm here. That happens to all of us, but her on a regular basis. The locus coeruleus is making norepinephrine on a tight margin. Dopamine synthesis is depressed. Sleep is fragmenting. Dural vasculature is reactive. Vagal tone is suppressed. Glymphatic flow at night is suboptimal because she's not getting deep sleep. Yeah, she was really poor fractionated sleep. So what does she need? GYN evaluation for menorrhagia, right? Excessive bleeding, because we have to stop the leaking. Iron repletion to ferritin, 75 minimum, maybe 100, depending on how that restless leg syndrome goes. Vitamin C, minimize that coffee and make sure she's not taking the coffee or her iron anytime near when she's taking the coffee, right? And that's where every other day dosing can maybe easier to do that sometimes, to maybe like, can you skip, maybe not have the coffee at a certain time of day and get that iron in there. And then even just going through her sleep audit, like a sleep hygiene of saying you need to go to bed at a regular time, right? I always stop short of sending people for sleep studies because, even if their symptoms persist after iron is up and their symptoms continue, it can be sleep apnea. I mean, certainly we've treated her for that, but I don't necessarily want the person to go on a
CPAP.
CPAP. Yeah, exactly. So sometimes that's a little bit hard because there are certain places that it doesn't matter if they're coming in, they're getting a CPAP. And there are other places that do a good job of, no, you don't need this, but you need that. But certainly sleep hygiene, getting the right amount of sleep, going to sleep similar time, having a certain, no blue light before bed, like turning off all the devices, at least 90 minutes to an hour or so before they go to bed, that sort of thing. Resonant breathing prescription, certainly having them do, I like alternate nostril breathing as a means of training breathing, maintaining a certain rhythm. I find that the most helpful. It resets the autonomic nervous system. That's what I prescribe. And then just recheck labs at 12 weeks. And then keep checking those symptoms. So you have to write these all down. Make sure you keep coming back to the list and check them off as they go away. And it can be arduous, but it's the best way to help that patient is somebody has to keep track of all the details. And that's often us because we're not there every day. It's easy for us just to ask what we can see. Now, what you're going to see over the next, say 3 months, it's a different person. Their sleep starts deepening, the restless legs settle, brain fog lifts, HRV climbs. That's an important one. If they have that app, that's always a good app to use. Headaches taper. The patient says, I haven't felt this clear in years. I mean, that's what you want. I mean, that's not magic. That's iron physiology, meaning clean mechanics, meaning decent sleep and appropriate care. So, and then you get their, and then we're helping them get their body back online. That really just magnifies the effect. So it's pretty awesome when you see that go through. Okay, so here's what I want everyone to take from today. Iron is one of the most consequential molecules in the human nervous system and one of the most underinterpreted in clinical practice. It runs the choroid plexus that makes your cerebrospinal fluid. It runs the brainstem nuclei that regulate your autonomic light. It builds the dopamine and norepinephrine that gate your sleep, motivation, and your stress responses. It supports the dural vasculature that decides whether your head feels clear or pressured and in excess or in the wrong compartment. It drives the slow oxidative damage that underlies major neurodegenerative diseases, right? So neurodegenerative diseases. This is the main driver. This is one of the big drivers behind that. So I think that's, I'm measuring my iron on a regular basis here. So, and I never did that before. So this is word to the wise, right? So when we miss iron, we miss it a lot. When we read it carefully, ferritin with transferrin saturation and C-reactive protein in the context of the patient's actual symptoms, we open a window onto the metabolic substrate of cranial physiology that no manual technique alone can reach. So the osteopathic lens is this: the body is coordinated. It's a coordinated signaling system. The hands work the mechanics. The labs read the chemistry. The sleep, the breath, the movement, the nutrition do the maintenance. None of it works alone, and none of it works without the others. What we want always is the system as a whole, receiving clean input, running on adequate substrate, clearing its own waste, and able to come back to baseline when life pushes it. Iron is one of the small metals that decides whether that system stays coherent. Pay attention to it. Coherence is health. Loss of coherence is disease. Iron is one of the currents underneath. So thank you for listening to the OsteoSignal podcast. I'm Neil O'Neill with Autumn and Brent Mayberry. And until next time, pay attention to the signals.
Thanks, Neil.
Thanks, Neil. See everybody.
Thanks for joining us on another episode of OsteoSignal with Neil D. O'Neill. For more information, please visit pursuitpt.com or pursuitperformancetraining.com. Want to show your support for the podcast? Give us a like, click subscribe, and leave a comment or review. We appreciate it. Our music was written and performed by Sky Toes. Copyright 2026 by Neil D. O'Neill.